I welcome you all to this instruction course on peri-operative challenges during phacoemulsification cataract surgery. We have an expert panel consisting of Dr. Chitra Ramamurthy, Dr. Soni George, Dr. Neena, Dr. Manoj Pradhaban, Dr. Marian Poli, and Dr. Anil Radhakrishnan. Without much ado, let's go on to the first talk on peri-operative pressure changes associated with phacoemulsification by Dr. Manoj Pradhaban. Over to you, Dr. Manoj.
Good morning, everyone. First of all, let me thank Dr. Sandhya for giving me this opportunity. I'll be talking on perioperative pressure changes during phacoemulsification. So the perioperative period is pre-op period, the intra-op period, and post-operative period. So what about the preoperative period? Topical anesthesia is IOP neutral, whereas peribulbar anesthesia can raise the pressure by about 10 millimeters of mercury. If you're concerned about that, you can reduce that with the help of a ball compression. You can bring it down back to the pre-mean IOP. Be mindful about the pupil dilation in angle closure disease, especially if you have not done a laser PI. Intraoperatively, we know for some time now that the pressure increases during phacoemulsification to about 60 millimeters of mercury. There could be transient intraocular pressure up to 100 millimeters of mercury during some of the steps, like viscofill of the anterior chamber, hydrodissection, and IOL implantation. The risk of optic atrophy is possible in compromised optic disc. The IOP depends on the fluidics parameters, bottle height, aspiration flow rate, fluid escaping through wounds, nucleotomy techniques, and vacuum settings. The higher vacuum develops during occlusion, and for better anterior chamber stability, we increase the bottle height, and this will increase the intraocular pressure. And when there is a sudden eating up of the nucleus and there is a loss of chamber pressure, there is a big fluctuation that can happen intraoperatively. This higher AFR needs higher bottle height. So what is the problem with higher bottle height? You have high IOP. This compromises the blood supply to the retina and optic nerve head, and adverse effects are on vulnerable optic nerve heads. There is also higher endothelial loss and greater postoperative inflammation. This study by Vaishali Vasavada, they looked at two parameters, a low parameter and a high parameter. In the low parameter, the AFR was kept at 20 and bottle height was 70 for sculpting and chopping, whereas for fragment removal, it was 90. And for higher parameters, they kept the bottle AFR at 40 and bottle height at 90 for sculpting and chopping and 110 for fragment removal. What they found was that maximum intraocular pressure was 86 millimeters of mercury when the AFR was 40 and bottle height was 110. And these peak IOPs happened in foot pedal 1 and when there was an occlusion of the tip. Intraoperatively, what they found was that the surgical time, the fluid used, and the cumulative dissipated energy was higher in the low parameter group, but in the low parameter group, there was lower fluctuations in the intraocular pressure. This in turn resulted in clear corneas postoperative day 1 and decreased anterior segment inflammation. This study looked at the early postoperative intraocular pressure after cataract surgery. So the mean IOP was 15 to start with. In the early post-op hours, after 4 to 6 hours, it increased to 24 millimeters of mercury, which started coming down with time. By 24 hours, it was back down to 18.3 millimeters, and by day 7, it was 16 millimeters of mercury. So this is a patient who was 60 years of age, who was POAG with 18 pressures, on 2 anti-glaucoma medications with stable visual fields and visually significant cataract. What next? Do you do phaco alone or a phaco trab? So cataract surgery can be an effective mix. It is minimally invasive, small corneal incision, excellent safety profile, proven sustained IOP lowering, and all options remain for future intervention. So what are the signs of lowering after cataract extraction? In open angles, there could be remodulation of the extratrabecular matrix because of raised expression of interleukins 1. In narrow angles, the level of IOP lowering is proportional to the angle widening. So anterior vaulting may be a predictive factor. This is not very effective in PACGs where there is an extensive peripheral anterior synecdoche. When we compared phacoemulsification versus phacotrab in narrow angle glaucomas, we found that both did produce a lowering of intraocular pressure, but phacotrab had a better edge. And there was a more drop in number of medication use also with phacotrab. Reduction in intraocular pressure after cataract extraction in ocular hypertension treatment study. So there was a sub-study which looked at the cataract extraction in ocular hypertensive patients. They found that at 36 months, about mean pressure of lowering of 4 millimeters was possible after cataract surgery. Another interesting data is that about 40% of the patients had more than 20% decrease in, more than 40% of the population had decrease in intraocular pressure of more than 20%. Intraocular pressure increased only in 10% of population. That was, it was marginal. Coming to long-term effects of phacoemulsification on normal-intensive and ocular hypertensive eyes, the interesting thing is, as the mean IOP preoperatively was higher, they had a higher change in intraocular pressure. So you can see that the first group had 6.7 millimeter change, whereas when the pressures were in the normal range or in the mid-teens, there was not much of a change. So things to consider, patients with a lower pre-op intraocular pressure may have higher IOP after phaco. And the pre-op IOP was between 15 and 17, 55% of them had lower IOP, 30% had higher IOP, and 15% had no change. If IOP was less than 50 millimeters to start with, 55% of patients had higher IOP. Post-trabeculectomy patients, IOP may increase by about 2 millimeters on an average, and 30 to 50% of patients may require additional anti-glaucoma medications. To conclude, phacoemulsification alone reduces intraocular pressure, and reduction in anti-glaucoma medication is possible. Thank you.
So
The
do we have?
importance of understanding this pressure changes.
Yeah. Do we have a question? I mean, time for a question? Yeah. So Manoj, I think I don't remember the study. There was something in the long term which says that the pressure comes down by 1 millimeter if you do cataract surgery.
That depends on the initial pressure, sir, the population they have studied on. So in this particular study that I showed, there were patients who were hypertensive and normotensive. So the normotensive patients don't have that much of a response, and the pressure reduction lasts only for about a year or two. After that, it comes down to into the mean. Whereas the start off with the pressures were higher, there you can expect more dramatic reduction in the pressure.
So this is from a glaucoma consultant perspective. As far as cataract people are concerned, what is the importance is this, if you're operating under low phaco parameters, so the shatter of the pieces will be less and the corneal clarity will be more. And more importantly, in certain special situations like IFIS or posterior polar cataract or in high myopes where the scleral rigidity is low, you will have to enter the phaco probe with low infusion pressure because you want a stable chamber, low infusion pressure. So proportionately, you will have to reduce the vacuum and aspiration rate so that there is no sudden shallowing or collapse of the anterior chamber. So in those situations, the chamber will be stable. So you will be able to do the phaco safely. Thank you, Dr. Manoj, for that excellent presentation. Next, we'll move on to the next talk by Dr. Anil Radhakrishnan on optimizing ocular surface during phacoemulsification.
Thank you, Sandhya. I think this session deserves a special mention in that you have taken multiple specialists and brought it in one umbrella. It's a very good session. So I think I think pterygia obviously you have to take it out before you do cataract surgery. But when should we take out the pterygia? It depends on how much it affects the cornea. So if it is only a small atrophic pterygium right in the periphery, you don't have to really bother about it. But if it is affecting your keratometry values, better to take it out. As you see in this patient who had around 6 diopters of astigmatism, and that blue color indicates flattening corresponding to the head of the pterygium. And once you take it out, it's less than 0.75 diopters of astigmatism. So we all are aware of the lacrimal function unit. I think it's a very boring topic, but we know that there is sensory feedback coming from whole of the eye, even the upper part of the nasal cavity that goes right up to the trigeminal nucleus. And from there is some connection with the superior salivatory nucleus, and the efferent pathway goes out through the geniculate ganglion of the facial nerve. There is the parasympathetic outflow that reaches the ciliary ganglion, and it gives information for the lacrimal gland to secrete the tears, both accessory as well as main lacrimal gland. So even at the basic level, you have some amount of reflex tearing that is happening. The sympathetic output is from the superior salivatory ganglion that is also contributing. And we have some things which we are not exactly still very not clear about. I would digress a bit. This is an international association for the study of pain. They define pain as an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. That is important, actual or potential tissue damage. So again, if you look at the pain pathway, the fibers reach the trigeminal ganglion. There are multiple things in the brain. First is the transduction, that is the receptors perceive the pain. Second is transmission to the respective ganglion. If it is the body, it is the dorsal nerve root ganglion. If it is from the eye and the ocular surface, it is to the trigeminal ganglion. At that area itself, there is some modulation of pain that is happening. That is actually working through the cortex. If you can have connections with the thalamus. You have connections with the paralimbic system. You have limbic system is very much involved. And if you have more cortical activity, that is also suppressed. So you can think of people who are really busy. They won't bother so much about the post-cataract dry eye. But people who are basically, I'm just extrapolating, but people who are just sitting at home, they are likely to complain more about it. And that is one thing. First is transduction, second is transmission, third is modulation at the ganglion level, and third is the what is perception. Perception is at the cortical level. From the thalamus, there is connection to the cortex and a lot of things which we have not really understood. So a lot of things can modulate pain there. And it is also well known that once the pain pathways are activated, that is all very much documented in people who manage chronic pain. When the pain pathways are activated, even if the stimulus is not there, the pain pathways can still keep on running. So you have this A delta which conducts the fast pain. That is when you have a corneal abrasion, you have a sharp pain. That is through the A delta. While the slow pain, you have this dry eye and dysesthesia and all these. These are through C fibers. So in the preoperative planning, if you have a topography like this, you see some red thing in this thing, you have to repeat it. You have to put a lubricant and repeat it, and it should be normal most of the time. That is because of a random dry spot that occurs on the cornea. The problem with that is if you have dry spots on the cornea, that can interfere with the keratometry. And sometimes if you are going for a toric intraocular lens, as you see in this patient, there can be significant difference in the lens power that you calculate. So whenever you see a patient in the clinic, you have to see the patient under slit lamp. It's not just enough to see under a diffuse illumination like this. When you think a bit of redness is there, it can indicate dry eye. You have to look at the parallelepiped image. You can see these small white spots under the fluorescent, and that tells you that there is some punctate erosions. Then punctate erosions will not happen unless the patient has dry eye. It is not possible to have punctate erosions. So whenever you have punctate erosions, you have to treat the dry eye and then only take up the patient for surgery. Otherwise, you are going to have an irritated patient. It makes sense to do a tear breakup time in all the patients, So I don't expect everyone to do dry eye workup and all that. Just put a drop of fluorescent and look at the tear film breaking pattern. So if you see a random spot which happens very fast within 4-5 seconds, normal time tear breakup time they say is in about 10 seconds. If you see the tear breakup is happening within 4-5 seconds, you know that there is some amount of dry eye, which is very common in urban population. So that has to be taken into consideration before you take the patient for cataract surgery. So if it is abnormal, you have to do a thorough evaluation. You have to do Schirmer's, you have to do other things. But generally, just put a drop of fluorescent and have a look at the patient under slit lamp. That's all what you want. There are a lot of drugs, especially in the population that we do cataract surgery, which can cause dry eye, antidepressants, antihistaminics. Among the BP lowering drugs, beta blockers are notorious, but nowadays people are not very much using beta blockers. This losartan and stuff like that, it does not cause. Calcium channel blockers are actually helpful. If you have long-term diabetes, there can be some amount of diabetic neuropathy, and that can contribute to dryness. And if you have a connective tissue disorder, obviously you have to work up and make sure that things are stable before you touch the patient. So there are a lot of investigations which I'm not going into. But is dry eye common? It is pretty common. I think if you look at a meta-analysis of 9 studies which are non-industry based, we see that about 37.4% develop dry eye after cataract surgery. There are a lot of factors which are involved. I think I'll come into that later. So before we go that, just a glance of the cornea, we have a very prominent some subbasal plexus in the cornea. Cornea is the most sensitive structure in the human body. Our periocular skin, if it has X, cornea has 300X or minimum 100X the time of sensitivity that it has. It is about 4,000 nerve terminals per square millimeter and is exquisitely sensitive. So any cut in the corneal nerve, there will be some amount of dysesthesia. As you know, in LASIK, after LASIK, it takes almost 6 months for the corneal sensitivity to come back to normal. After keratoplasty, you see anesthetic cornea for up to 1 year. And in cataract surgery, generally about 1 month you will have dryness. At around 1 month, near about 25 days, you will have these neurite cells. Do you have 1 more minute? Yeah. At the end of 1 month, you have these neurite cells, and there is increase in the neural growth factors that are seen in the 25 days post-op, and that contributes to the symptoms that the patient has. So in the interest of time, I'll just say that cataract surgery causes sensory nerve damage at the incision, even though the incision is very small. And because of the less blinking, that also can contribute to the dry eye. So the factors that can contribute to the perioperative dry eye in the perioperative setting is, one is the type of procedure. If it is a large extracapsular or an SICS, you can have more dry eye, obviously. The type of drugs that you use, if you keep on putting this dilating drops every 5 minutes, you can have more dry eye damage. If you have the more like exposure, if you generally we tend to see very clearly, we put high illumination, basically it strains your eye as well as it can cause dry eye. Coexistence disorders like especially rheumatoid arthritis and stuff like that can cause secondary Sjogren's and can cause dry eye. And there is some evidence that cumulative dissipated energy during phaco also contributes to the dry eye. So I repeat, TBT and corneal staining is the only thing that you have to see. So if you have got mild dry eye, it makes sense to use artificial tears minimum pre-operatively at least 2 weeks before the procedure. Ideally 1 month before the procedure. It's better to use a dual acting agent, and hyaluronic acid is the one that is preferred, or you can use a combination of HP GOR plus a polypropylene glycol or polyethylene glycol. So if you can combine trehalose with hyaluronic acid, it is more beneficial. It takes almost 1 month for the sense to improve, and if you are giving omega-3 fatty acids, we have to give it for at least 1 month. So this is a study which compares basically 3 different groups. One group in which the dry eye, only routine post-operative medications were used. That means antibiotic and steroids were used. They had a speed score of 1.25. And group B in which they used dry eye medications after surgery, and group 3 in which it was pre-operatively used. If you see that the speed scores are less in a people in whom pre-operative medications are used. I think most of these studies are industry sponsored, but still there are some data which says that pre-operative usage is helpful in quite a few patients. So I'll sum it up saying that if you have a patient with dry eye, as much as possible to go for a smaller incision. Consider avoiding astigmatic keratotomy. Then limit the drops. Don't put dilating drops and NSAIDs if at all. Then use preservative-free drops as much as possible. Reduce the amount of illumination that you use. Make it minimum as comfortable to you. Limit the surgical time. That is again very important. Then reduce the surgical trauma. As if in femtosecond laser, if you have the suction rings on the limbus, that can also lead on to dry eye. And if you have moderate to severe dry eye, you have to treat it more vigorously with autologous serum and other stuff. And if you even in advanced dry eye like Stevens-Johnson syndrome, it is possible you can do a punctal plug and improve the tear volume and then do a cataract surgery. You should also realize that in SJS, the mammalian glands are almost not there. So you have to use some agent which has lipid also in that. I think in the interest of time, I'll wind up. So cataract surgery is something that causes dry eye, and the treatment of dry eye is demanding. And the optimization of ocular surface is very important to ensure a surgical outcome. Thank you.
Thank you, Dr. Anil. I have just one question. When you're treating a patient for dry eye, when will you consider cataract surgery in that patient?
Okay, so I think it depends on the dry eye that you are going to treat. Like if it's an established Sjogren's syndrome and all that, get the inflammatory parameters under control, ESR and CRP. And as I said, the tear breakup time and fluorescent staining, if you try to reduce it by putting the patient on cyclosporin, use it for minimum 1 month, ideally up to 3 months. minimum 1 month. Usually by that time, along with the regular hyaluronic acid and all that, it will improve, and then take the patient for surgery. So 1 month it's very difficult now that we have very great competition, especially in places like Kochi. But at least 15 days try to push the patient and then do cataract surgery.
Thank you. Next talk is by Dr. Marian Poli on phacoemulsification in presence of orbital and ocular adnexal problems. Over to you, Marian.
Yeah, good morning, everyone. Thank you, Dr. Sandeep, for putting up such a nice IC. So in this presentation, I acknowledge all my cataract surgery colleagues. So let us see what we can do. So this is a huge topic. I will just put up a few points in each area. So coming to lacrimal drainage anomalies. So total NLDO, no doubt, you have to do DCR or DCT. After DCT, wait for two weeks. DCR without intubation, wait for 3 weeks and then do IOL. DCR with intubation, wait for 6 weeks. This is for the stabilization of the bacterial flora of the conjunctival fornix. Partial NLDO, if the patient is symptomatic, do a syringing and you can actually proceed with IOL. What we have seen is they might become total NLDO after cataract surgery. Canalicular blocks, Roplas is negative, but syringing shows common canalicular block. So here decision is based on your conjunctival swab. If the swab is negative, you can go ahead with IOL surgery. If the swab is positive, you have to treat and then go ahead. But before putting it as common canalicular block, do a probing and confirm, because sometimes atrophic sac, that is very small sac, mimics like canalicular blocks. So this is one of our patient, adenocystic carcinoma maxilla, status post maxillary reconstruction, radiation, had NLDO, ectropion, lag of thalmos. We did DCT and then later underwent cataract surgery with suture tarsography. So coming to blepharitis, we know the organisms. Here the thing is, vitreous tap and the lid margin bacteria flora was identical in almost 82% of cases. It was from an old study, but still it holds relevant. So you have to clean the lid, artificial tears, then oral doxycycline in recalcitrant cases. But in some cases, still it will be very recalcitrant. In that case, you have to do an office lid massage to clean the lid properly and then go ahead with cataract. Chalazion and cataract, no literature evidence, but it is prudent to wait till complete resolution of the chalazion. The thing is, it can have acute inflammation in the postoperative period. Coming to lid malpositions, ptosis, mainly we see aponeurotic ptosis in this age group. So mild ptosis, you can go ahead, but in severe ptosis, again the discussion between the surgeon and the patient. So between cataract surgery and ptosis, at least 3 months interval. The main thing is now everything is like, highly demanding. Cataract surgery is like a refractive surgery. So when we are planning toric IOL, be careful in patients with ptosis. And another thing is roll out myasthenia gravis, because if we are doing surgery under local anesthesia, this local anesthesia, that is peribulbar block, can precipitate myasthenia gravis. So this is one of our patients which after cataract surgery presented with the total ptosis, and later we diagnosed it as ocular myasthenia. So considering phaco and ptosis, you can have ptosis aggravation after phacoemulsification. If it is done under local anesthesia, speculum can cause ptosis, topical steroids can ptosis. Bridal suture is hardly used nowadays, but still it can also induce ptosis. Coming to entropion and ectropion, here the one good thing is in the large data published in Canadian journal, no risk of post-op endophthalmitis, but there are some cases it can induce corneal aberrations, infections, etc. So again, there is a controversy. It can be done, entropion can be corrected before, along with cataract, or even after. But again, depending on case to case. So this is a one-night patient. Left eye is post-PK. So right eye, we did entropion first and then cataract surgery. Coming to another entity, very common, that is thyroid eye disease. In thyroid eye disease, always, if possible, do topical phaco. Because peribulbar block can increase intraorbital pressure, can lead to complications of cataract surgery. And always, surgery has to be done in inactive phase. The thing is, sometimes reactivation can occur following phacoemulsification. And the most important thing is refractory error surprise. Around plus minus 1 diopters have been reported. The thing is, there is a volume fluctuation of the orbital volume in thyroid patients. So this is again our patient came with active disease. Then later she underwent decompression radiation and followed by IOL surgery. Coming to ocular prosthesis, it is always follow one-night protocol. Each institute will have one-night protocol, and the socket should be healthy. no need to remove the prosthesis during the cataract surgery. Coming to lid tumors, so malignant lid tumors, always tumor first. So benign tumors, again discussion with the surgeon and the patient. You can go ahead with cataract and later on they can come for the tumor excision if they are interested. So this is our one-eyed patient actually. You can see the black cataract with the basal cell carcinoma. So we did tumor surgery first and reconstruction, then he underwent cataract surgery. Coming to orbital tumors things are really different. Here always tumor first, because we know orbit is a Pandora's box. Radiology also can be deceptive sometimes. So we need a histopathological confirmation. So in this case we can see she had hemangioma with a mature cataract. Right eye again schwannoma with the cataract. So we did tumor first and then cataract surgery. Again, coming to the tumors after treatment, especially after orbital radiation, they can have increased incidence of intraoperative PC plaque and postoperative CME. So this has to be mentioned and to be taken care of. And especially lacrimal gland tumors do a punctal cautery during the cataract surgery so that the dry eye is very severe, to be taken care of. Facial palsy and lag ophthalmos, temporary suture tarsography, there is a neurotrophic element or nocturnal corneal exposure, and that can be released after 2 weeks so that patient will be comfortable and no need of any stress also. Skin diseases always do in inactive phase. We come across pemphigus cases, so they come like this with mature cataract. So always consult a dermatologist before we embark on IOL surgery. So to conclude, there are lots of conditions and preoperative evaluation for adnexal problems very, very important. Selection of anesthesia nowadays mostly topical, but still. So careful decision making is a must to get very good result. Thank you so much.
Thank you, Marianne, for that excellent talk, which covered all aspects of ocular adnexial problems. I just have a doubt. Suppose you have a patient with chalazion, and then you said it's better to tackle it before going ahead with cataract surgery. How long or how short can we wait before the cataract surgery?
At least 1 week. After INC, after 1 week, the wound heals, then you can go ahead.
Thank you. So now we have Dr. N. Sandhya, who's going to talk about challenges in phacoemulsification after vitreoretinal surgeries.
Thank you, Dr. Nina. So, preoperative considerations. All patients should have a careful slit lamp examination to look for any pre-existing posterior capsule rent which can arise from trauma of the previous surgery. Biometry should be accurate in these patients, and ideally, if available, optical biometry should be done. And optical biometers have a silicone oil mode for eyes filled with silicone oil, and newer ultrasound biometers also have this silicone oil mode for IOL power calculation. All patients should be informed about the guarded visual prognosis before surgery itself because of the underlying retinal pathology. Now coming to intraoperative consideration, this patient had undergone pars plana vitrectomy in the past, and you can see the conjunctival scars corresponding to the previous surgery. Pupil was dilating well and the nuclear sclerosis was grade 2 to 3. Trypan blue was used to stain the capsule, and you should never make a baby size rhexis in these patients because these patients already have a deep anterior chamber and there will be difficulty in pulling out the nuclear pieces. And the rhexis should also overlap the IOL optic all around. The posterior capsule in these post-vitrectomized eyes are vulnerable for posterior capsule descents. Hence, the hydrodissection should be very gentle. Now, these vitrectomized eyes, the vitreous gel is replaced by fluid. So, there is no gel support for the eye and for the cataract. So, the cataract is at the deeper plane and the anterior chamber is deep in these eyes. So, whenever you are introducing phacoprobe, the infusion pressure should be lowered so that there is no sudden deepening of anterior chamber which can cause pain to the patient and also will make the nucleus manipulations difficult. So you need to reduce the infusion pressure. So when you reduce the infusion pressure, there may be collapse of the anterior chamber. So proportionately, we will have to reduce the aspiration flow and vacuum. So during cortex removal also, we need to reduce the infusion pressure and aspiration flow rate. So after this, a single piece lens was placed inside the back, and whenever there is doubt on the integrity of corneal tunnel, you can put a suture there. So these eyes, because of the low scleral rigidity, they are more prone to what is known as lens iris diaphragm retropulsion syndrome. Here, whenever the eye is filled with OVD or when we are starting the infusion, the iris is thrown back onto the anterior capsule. There is 360-degree iridocapsular contact, which can lead to reverse pupillary block, and this will lead to sudden deepening of anterior chamber, stretching of ciliary body, and can cause discomfort to the patient, more so if they are operated under topical anesthesia. So we can reduce the infusion pressure when you're introducing the phaco probe to reduce this. And this can happen at any time of surgery, that is even during the cortex removal. And you can lift the iris off the anterior capsule using a Sinskey hook so that the fluid equilibrates between the anterior and posterior chamber, and the iris and the anterior chamber, they come back to their normal position. So this patient had undergone pars plana vitrectomy with silicone oil injection earlier. So as you can see here, when the rhexis was initiated, the lens started moving, and also there was great difficulty in initiating and continuing the rhexis, which indicates generalized sonule weakness. So when hydrodissection was done, you can see large amount of oil. It started coming from behind. So this is coming through the sonules because of the weakness. And this much amount of oil is quite uncommon during cataract surgery. What we usually see is this, that is emulsified silicone oil bubbles in the anterior chamber, which can be easily washed off or can be removed with injection of OVD. So since this was a soft cataract, so you can see the oil still coming. It was prolapsed into the anterior chamber. And after protecting the endothelium with dispersive OVD, this was emulsified in the anterior chamber using low phacoeparameters. Then the cortex was removed by pulling it tangentially rather than radially, so that there is less stress on the sonules, and then bag was filled with OVD and a CTR was inserted. So this CTR gives equatorial support to the capsular bag, and it uniformly strengthened the sonules. So once CTR was inserted, once this was inserted, the oil stopped coming. So because it is strengthened by the CTR. So afterwards, the bag was filled with OVD and the lens was placed, and this case was handed over to VIA surgeon for oil removal. Now the cataract in these eyes tends to be typically of nuclear sclerotic type, and they will have a leathery texture and a hard endonucleus. So the clear corneal tunnel should not be too long, because already the anterior chamber is deep in these vitrectomized eyes. So in that case, if the clear corneal incision is long, you will have to hold the instruments more vertically, which will cause difficulty during the nucleus manipulation. And also you should chop the nucleus into multiple pieces, and then after protecting the dispersive OVD, you should emulsify these pieces using low ultrasound energy so that there is less damage to the corneal endothelium. So this patient had a near total cataract, and he had already undergone silicone oil injection. You can see the posterior capsule plaque here, which is not very uncommon in these oil-filled eyes. You should never try to remove this through the anterior route, which can cause posterior capsule dehiscence. So this can be removed by the pars plana route during oil removal, or this can be YAG lasered later. And then this posterior capsule in these eyes filled with silicone oil, they have appear to be thickened, and they will have a sheen-like appearance. Now this patient had undergone vitrectomy earlier, and the pupil was not dilating well. During phacoemulsification, you can see there was billowing and fluttering of iris, and there was progressive intraoperative miosis, which are signs of intraoperative floor P iris syndrome. So once the phacoparameters were reduced, the fluttering and billowing reduced, and the chamber became stable, and we could safely complete phacoemulsification in this patient. So in this case, you can see the pupil was not dilating well. There was posterior synechiae, and there are silicone oil bubbles under the conjunctiva here. These are the silicone oil bubbles under the conjunctiva. So after injecting OVD, the posterior synechiae were released, and here iris hooks were used to provide visualization during cataract surgery. So coming to postoperative considerations, all these patients should have a thorough retina checkup postoperatively and refer to the vitreoretinal surgeon for the follow-up of their underlying retinal problem. So to summarize, a thorough preoperative evaluation is needed to look for any phacodonosis or pre-existing posterior capsule rent. These patients are more prone to lens iris diaphragm retropulsion syndrome. So whenever you're introducing phaco probe, the infusion pressure should be reduced. They should not have a too long corneal tunnel, should not make a baby size rhexis in these patients, and hydrodissection should be careful. Don't try to remove the PC plaques through the anterior route during cataract surgery. And all these patients should preferably have a postoperative retina evaluation. Thank you.
Thank you, Dr. Sandhya, for those excellent demonstrative videos. I have a question. Maybe it is stupid, but what do you have any IOL preferences when you do surgery? The type of IOL, single piece or multi-piece? Because
don't have-
once or twice, when I've done pediatric cataract surgery, we had a patient with PHPV, and I'd put a single piece in the bag, and the VR surgeon had to go from behind and cut the plaque. The single piece just came out. So now I just make sure that you always use a three-piece lens.
I don't think there's a preference for lens in these eyes,
Because
but
the
silicone
memory-
lenses should be avoided in these patients. Otherwise, for cutting plaques, I'm not aware of any lens preference. Preferably, silicone lenses are avoided.
Yeah. Any comments, Dr.
Dr.
Anil?
Anil?
Same thing I would say. For adults, I don't think it matters, man. Because they can make a small cut with a vitrector, they can make a 3 mm opening. But in a pediatric, the pressures are different when the capsular fibrosis happens. And maybe in such patients, this single piece is not a good option.
Yeah, I always feel three-piece has a better memory, and I think when you're expecting some
Only,
fluctuations,
yeah, then thing is this single piece lenses, the haptics usually unfold in a controlled manner. So, but three-piece lenses, see, you should be very careful while injecting these lenses. And also, see, if there are high-risk cases, it is better to have a backup of three-piece lens, because if there is any PC rent, which is unexpected, then you can place the lens in the sulcus and do an optic capture.
okay, thank you.
One small question. See, in a lot of patients, the VR surgeon tends to keep the oil because they have a like long-standing RD. So you have to make the necessary calculation.
Yes.
altogether.
See, actually, in these ones, we have the silicone oil mode. Actually, see, newer optic ultrasound biometers also have the silicone oil mode. You can just calculate with that mode for these patients. Madam. What? +3.
Yeah.
Yes, sir.
Yeah.
0.721. What we are getting.
So moving on, we now have Dr. Soni George, who's going to talk about refractive surprises after cataract surgery.
Very good afternoon. At the outset, let me thank Dr. Sandhya for giving me an opportunity in this well chalked out IC on perioperative challenges, especially with input from our fellow super specialists and their guidance. So basically now cataract surgery, whether it's cataract surgery or a press legs, it has to be precise and be delivering accurate results. And no amount of residual errors will be accepted. Even higher order aberrations will be very less tolerated. So now we use premium IOLs like aspheric, toric, multifocals, etc. And the refractive surprises mainly are the spherical refractive surprises, the cylinders, in which during biometry a cylinder was overlooked, or in a toric IOL where again the calculation was wrong, or there was a intraoperative rotation, postoperative rotation, and the higher order aberrations. So the main sources of surprise are the main thing is the biometry, the axial length calculation, keratometry. Each diopter of difference can give you 0.9 diopters of IOL error. The choice of the formulae, which is very important. Clerical errors. By clerical errors, what I mean is when the optometrist takes the keratometry value and feeds it to the biometer, a single digit can make such a huge difference. And then IOL rotation in the toric version of IOLs, and this surgically induced astigmatism. Most of us still continue keeping it at 0.5 when we started. Now it's less than 0.25 actually with the better incisions, and as our techniques become better. So that also has to be revisited. So for example, this patient comes with a grade 3 nucleus 624 vision. Everything is fine, but then he lands up with 5/60 vision with a -5 diopters 6/6. Obviously, he is going to be very, very unhappy. And this person again with a VVT and with a -2.25 cylinder. And now he lands up with -1 cylinder, which also is equally not acceptable. So again, coming to the axial length measurement, you can either do it with immersion immersion gives almost as good results as optical biometry, or probably in mature cataracts, we have to go in for the immersion, white mature cataracts. Always in a high myope or somebody with a posterior staphyloma, always make sure you have a B-scan vector so that we do not miss out the posterior staphyloma or the calculation at which point we take it. And in any doubt, if there is a difference of 0.5 diopters between the eyes in the axial length, then definitely you should repeat it by a different operator. And you always have to look at the peaks. The probe, the cornea, the anterior and the posterior lens, the retina sclera, all should be equally long, and then there should be an attenuation of the orbital fat. Any differences should be erased. And optical biometry, it's a non-contact, no anesthesia method, and the precision is 0.101 to 0.02, and the measurement is from the anterior cornea to the RPE. Very precise. Much more important is that it acquires all the information in one go. So clerical error is almost impossible in these cases, because the machine takes the keratometry also. The feeding in, there's no feeding in which happens. And nowadays with the KSOS OCT incorporated, things are even better. So keratometry, you should take a minimum of 2 modes. Manual keratometry, nowadays most of us do ARK. If you have topo, pentocam, etc., very good. And if there's a difference of more than 1 diopter, please repeat. And if the keratometry does not tally with the refraction again. And corneal power less than 40 and more than 47, you have to repeat. And difference in corneal power of more than 1 diopter or astigmatism more than 4 diopter, all this previous LASIK surgery. And if you're unsure, again, these are all things to be careful and to be repeated. And post-refractive surgery eyes, obviously the axial length, the keratometry, the IOL calculation formula, all this should be important, because usually there will be an overestimation of the K value and underestimation of the IOL power, and leading in a post-operative hyperopia. So post-refractive surgery, you have to go at whichever method, starting from the contact lens method. But now we have so many newer formula like the Shamas, the Arenberry double K, the Hill RBF, etc. And this will give a broad outline for a normal to a myopic eye. You can either go for Holiday 1 or SRKT. For a shorter eye, Hofer Q. Hages for post-refractive surgery, and most of the, and Holiday 1, Holiday 2, and the Universal, Barrett Universal 2 will be a good this thing. And always revisit and recalculate your IOL calculation. Try to personalize your ray constants, and even reducing the stress on the zonules ultimately gives you a better ELP. So how to bail out once this has happened? A detailed reevaluation has to be done. Look at the ocular surface. Make sure is the refractive surface the real reason of the unhappiness. Maybe you think he is unhappy because of a small cylinder, but it may not be so. It may be a dry eye. So treat that. Check for IOL rotation in torics. Check for errors in biometry. Make a decision and a plan of action, and discuss with the patient in detail as much as possible. And you decide what is to be revealed and in which way it is to be revealed. So in certain cases, we'll have to go for a IOL exchange, like that -5 diopters. Obviously, you'll have to go for an IOS. You can go for a piggyback IOL. And IOL realignment, obviously in a toric surprise. And in small residual myopia or hyperopia or in astigmatism, you can go for an excimer touch-up or a bioptics. So this is one such lens which had to be explanted. So make sure most doses, especially in the multifocals, etc., be very careful not to damage any of the structures, including the cornea. Here I am just extending the wound a little bit and then injecting high density viscoelastics, trying to protect the cornea. Dial the this thing out of the bag, the optic and the haptic out of the bag. And once you stabilize and you get a good grip over the optic haptic junction, you can actually pull it out with a 4 millimeter incision. You don't need to really cut the IOL. Now bring the haptic out so that you again push in a little bit of viscoelastic again over and below to protect the posterior capsule as well as the cornea. And once you do that, then you're sure you are not going to disrupt the cornea or the Once you do that, you can just yank it out. This I've extended by 1 millimeter, 2.8 to 3.8, it comes out. And after that, you can implant your the right powered IOL, and the bag is not disturbed, nothing is disturbed. You can just inject it into the eye and rotate it. In certain cases, it may not be possible. You may have to cut the IOL when it's a thicker lens. So again, you can either cut it halfway and then use the cut area to vex it at the section and remove it, or you can cut it into 2 full halves and remove it like this. And you can inject the next IOL. You can use a IOL scaffold technique also if you bring it into the anterior chamber. Okay. So this is how we deal with a refractive surprise. Obviously, toric IOLs we need to realign, and the higher order aberrations we need to treat it accordingly. We cannot do much about it other than stabilize the ocular surface. Thank you very much.
Thank you, Dr. Soni. Just one question. How will you approach a patient with post-op refractive surprise? Like first itself, will you go for IOL exchange or you'll have a stepwise approach?
If it is a significant residual error, like more than maybe 2.5 to 3, then obviously the patient is going to be unhappy and his vision is going to be nothing more than 6 by 60. In those cases, we really need to explain to the patient that, we may not say that the IOL power was wrongly calculated or anything like that, but then some problem in the position of the lens, etc., and we need to remove it. In those cases, it is always better to do it within 1 or 2 weeks, because before the fibrosis sets in, because pulling out the lens out of the bag, especially with the hydrophobic IOLs, will be much better in those situations. And toric IOLs, obviously, we will have to take up as early as possible. Tell him there is a slight change in the lens position. That's what I would generally do.
Yeah. Your opinion on Sulcoflex lens? I have used it some time ago, but
Yes.
not recently.
Now it is not available, unfortunately. I tried for a patient, but Sulcoflex, now it is not available. Piggyback definitely works. So it's a much a traumatic procedure. You don't need to cut the lens. You can put it. I've used a couple of lenses to correct the residual myopia, as well as a multifocal. The other eye multifocal and Sulcoflex multifocal, but that's a refractive lens. That's the only problem.
We are happy to take up questions from the delegates also.
Thank you.
And another thing is first, before if the patient is happy with the spectacle correction, you don't have to go for IOL exchange also. That we should talk to the patient and then we should come to a conclusion. So the patient is happy with spectacle correction. I think that is the first option, because IOL exchange is associated with some complications also and depends on the surgeon's experience also. So
That's what I was commenting. Like, first of all, the patient should be unhappy, and that is not the. If he is not unhappy, then we don't do anything.
leave it like that.
As a continuation of the previous question, there was some discussion that because Sulcoflex lenses were not available, ICLs can be used in place. The cheaper ICLs. Okay. So there's no cost advantage anyway.
So thank you, Sandhya and Drishti 2024 for giving me this opportunity. So today, with the modern technology, cataract surgery is one of the most routinely performed and, refractive surgeries with excellent results, and high expectations are there from both patient and the surgeon. So if you get a double vision after cataract surgery, it's a major distress not only to the patient, but a big surprise and disappointment to the operating surgeon. So let's look at some case scenarios. So this was a 40-year-old IT professional. He was myopic and he underwent femto-assisted laser cataract surgery in the left eye. Post-cataract surgery, he got very good vision, plano 6.6 N6. But this is his response on the glass appointment day. Doctor, everything is so clear, but double. And patient is clearly unhappy. So what went wrong? So he was myopic earlier. With the right eye, he's still using his myopic correction. He has 6.6 vision, both eyes. What did we miss or what did we overlook? So this is what we overlooked. He had an intermittent exotropia, which was missed, and it was more, decompensated in the left eye. What went wrong? So when a throwback into the past, he was anisomyopic, means he had more myopia in the left eye. He already had an intermittent divergent squint, but he was able to control it with his fusional convergence. But with the onset of cataract, it broke. The fusion was disrupted and it manifested into an exotropia of the left eye. And post-surgery, he regained his vision. Alas, the vision is so clear, but everything is clearly double. And that's the problem here. So what did we do for this patient? So he was extremely unhappy. He spent almost $1 lakh for the femto laser. And now he has double vision. So we tried everything, orthoptic exercises, prism glasses. He wasn't happy. Finally, we underwent and took up squint surgery for him. And he's now happy because he's able to see single. So you have to be careful in such patients, especially anisometropes with unilateral cataracts. When you're operating, please look for preoperative deviations. Counsel them for the postoperative diplopia possibility and the possibility of a squint surgery. Let's look at another case scenario. A 32-year-old gentleman, he had trauma in childhood. He had undergone corneal tear surgery, cataract surgery in childhood. He wasn't rehabilitated with glasses, so he had poor vision. He came to us for a checkup. In our enthusiasm, we checked him, and with a phakic correction, he was improving to 612 N8. So why not do a secondary IOL? He'll get good vision back, right? Yes. So we did a scleral fixated IOL for him. Post-surgery, his vision improved to 6.9 N6 in the right eye. So this is his preoperative picture, and now you can see he's clearly unhappy. Everything is jumbled up and double. Very clear, but double. So what happened here? Now this, remember, this was a patient who had trauma in childhood, had lost vision, had long-standing poor vision from childhood. And his fusion was disrupted in childhood at an age when he could neither suppress nor fuse. So he developed an exotropia, but since vision was not corrected, he didn't have any problem. Later on, we deliberately corrected his vision with a secondary IOL, gave him good vision, but clear double. So he landed up in a proposition of horror fusionist. He can neither suppress nor fuse. So even with prism glasses, he was unable to fuse. So this is something that you should keep in mind, especially in long-standing loss of vision, younger patients, traumatic cataracts, counsel them for post-op diplopia. So this patient is currently on Fresnel prism glasses in the right eye, you can see here, and he's undergoing orthoptic exercises. If he's able to fuse, we will take him up for surgery. Otherwise, we cannot. Let's look at the next case scenario. This was a patient of myasthenia gravis, well controlled on oral pyridostigmine and Vicelone. Ocular movements were full, no double vision preoperatively, had posterior subcapsular cataracts and underwent surgery in the right eye. Surgery was uneventful, but patient was unhappy. This is what happened. She developed a hypertrophy of the right eye. And this is her diplopia charting, which shows the double vision is more in the right down gaze. So what happened? So this patient had undergone cataract surgery under local anesthesia. And possibility is that probably it induced a myotoxicity to the inferior rectus muscle, and patient developed an inferior rectus paralysis and hypertropia. So in patients with myasthenia gravis, avoid injection anesthesias. No local anesthesia for myasthenia gravis patients. Please do them under topical, because even though they are well controlled, you may produce a new squint and patient will really get angry with you. So this patient was chewing her brains till her double vision resolved over 8 weeks with slow tapering dose of oral steroids. So next case is that of a 65-year-old lady with blurry vision. She had already undergone cataract surgery in the right eye. She had good vision, so she didn't really bother about the left eye. When she had a near total cataract in the left eye, she came to us. Visual acuity was 660 N24 in the left eye. Post-cataract surgery, she had good vision, but on glass appointment, she wasn't happy. She was not able to keep her eyes open. She was preferring to close the left eye. What was the problem? This is the diplopia charting. You can see there is a vertical diplopia, which is maximum in dextrodepression, very typical of left superior oblique palsy. So this was a disappointed patient. What did we miss preoperatively? This was a patient with a chronic right head tilt. We totally missed it. And this is a patient after prism glasses, happy. Because surprisingly and happily for us, the double vision and the diplopia and the squint was better with prism glasses. It was a small vertical squint we could manage with prism glasses. So if you look at the etiology of post-cataract surgery diplopia, it could be surgery-related, anesthesia-related, optical or refractive, but most of them are due to pre-existing strabismus which is missed or a new onset of strabismus. So already these conditions have been described. Surgical technique can sometimes lead on to double vision, but it's usually the anesthesia, especially retrobulbar anesthesia or peribulbar anesthesia, which can injure the rectus muscles, most commonly the inferior rectus, which can produce a vertical squint. Sometimes it can be ischemic injury or an inflammatory reaction, but surprisingly these are rare in today's scenario because of our shift to topical anesthesia. I'm not talking about this because it's been already described and discussed, but pre-existing missed disorders are the most common, especially a patient with dysthyroid ophthalmopathy with subtle redness coming to you. You may totally miss the injection over the recta and think of it as a conjunctivitis. Oculomotor nerve palsies, which are subtle, you may miss it. Myasthenia gravis, decompensation of a pre-existing heterophoria to tropia, horror fusionus, as I already described, in young patients with post-traumatic cataracts. And rarely, pre-existing macular conditions may be missed, like an epiretinal membrane or a macular pathology, which can produce true uniocular polyopia. So this was a study we had undertaken in our center to evaluate the incidence and causes of binocular diplopia following cataract surgery for a period of 6 years. And what did we find? Out of the 48,500 cataract surgeries which we did at our center, only 38 patients we could get with true binocular diplopia. That is a very small number, 0.078%. So this is an agreement with Costa et al.'s publication in which they found an incidence of 0.09%. But you know what? Surprisingly, 74% of all these patients who had binocular diplopia had double vision looking towards the operated eye, and they attributed everything to the surgery. So that is the big catch here. So what we found was that the majority of post-cataract surgery diplopia is due to a pre-existing cause, most commonly being a decompensated foveatotropia, mainly exotropia. New onset double vision is usually due to cranial nerve palsy, most commonly a superior oblique palsy, which is very subtle and may be difficult to pick up unless you really look for it. So preoperative missed diplopias again were due to pre-existing superior oblique palsies. Local anesthesia-induced diplopia is rare. With topical anesthesia, the risk is hardly there. And what we found that a simple binocular vision assessment, including Wirtz-Fodor test, stereopsis, Hirschberg tests, in most of the cases picked up the pre-existing double vision. And if you are suspicious, do a diplopia charting, and that would pick up the majority of the preoperative diplopia of about 95.2%. And also, what do we do for these patients? If at all you have a post-op diplopia, you could manage them with prisms or orthoptic exercises depending on the condition, and some of them will have to be taken up for squint surgery also. So the learning points would be that diplopia after cataract surgery is surprisingly rare and infrequent, but if it happens, it's going to cause you a lot of trouble. So be prepared to handle it. So basic binocular vision assessment, including a Wirtz-Fodor test, stereopsis, ocular movement analysis with or without a diplopia charting should be an integral part of your pre and post-op assessment. And I would recommend that all of you cataract surgeons take 1 minute to examine your patients in undilated state, because that will give you a clue regarding presence of any abnormal head postures, ocular misalignments, pupillary anomalies. And if you detect any problem of preoperative squint or double vision, do inform the patient about the post-op diplopia and the possibility for prism glasses and squint surgery. So the best approach is to anticipate in suspected cases, communicate with the patient, and be prepared to tackle it. Thank you very much.
Thank you, Nina, for that excellent presentation. I've got just one doubt. Some of these patients with mature cataract, they have a divergent squint. Do we have to do a squint evaluation before surgery after listening to a talk?
So yes, I think you please note that they have a divergent squint and inform them that you have a divergent squint pre-existingly. And if you get good vision, there is a possibility that you may not be able to fuse it. So most of them would be ignoring the image, but I have had a lot of adult patients which have done squint surgery after cataract surgery, not able to fuse the second image because of the exotropia. So it is, you should inform, otherwise they'll attribute everything to your surgery. Please take a photograph and document it also.
Next talk is by Dr. Chitra Ramamurthy. Madam needs no introduction. She is an expert phaco and refractive surgeon with international reputation. Dr. Chitra Ramamurthy will be speaking on strategic pearls to phaco in subluxations. Over to you, madam.
Very good morning to one and all of you. Thanks, Dr. Sandhya, for this wonderful opportunity, and KSOS for this my presence here. So this is a 12-minute talk, and I'm going to talk to you all in 7 minutes. So bear with me. So my due is to talk on the key strategies for subluxated cataract. So we know that when a lens is displaced from its normal position, but in the pupillary area it's subluxed, but it is not in the pupillary area, it could be anteriorly or posteriorly dislocated. The commonest cause for subluxation is traumatic and then only iatrogenic and other causes. And the main complaint is decreased vision and progressive changes in vision and increased astigmatism, amblyopia, diplopia, and of course signs of trauma. So we need to do a complete ophthalmic examination, and in a small child, we need to do a cardiac evaluation, metabolic screening, and a regular annual ophthalmic examination. And when you do refraction, you need to check which the myopic part or the aphakic part, which part the patient is able to see better, and give them glasses. And on a slit lamp, you will see that the AC is irregularly deep. There may be present of vitreous. There could be phacodonosis, and the phacodonosis is obvious in an undilated pupil because in the dilated pupil, the ciliary body supports it. You can look at the direction of subluxation, the quantum of subluxation, make the patient lie down. If in the supine position, the lens sinks down, then it's to be a pars plana approach. Then going on, you need to do all these evaluations, and if the fundus evaluation is not possible, you may have to do a B scan, and you have to use the latest formula. I'm going to go on to the key pearls which we need to keep in mind. The first thing, if it is a child, it has to be a cardiac evaluation. Fitness has to be taken. In adults, it can be a regional block. You should give IV mannitol, decompress the eye. There could be an intumescence of the cataract too. It could be a very elastic capsule too. So you need the positive pressure to be less in these eyes, and that makes a lot of difference. And the quantum of vitreous loss could be attended. You need to ensure that there's no vitreous, so you inject the tricot as and when you want. I would tell you when. Staining of the vitreous lens capsule, what you need to do is, you should not straight away inject Trypan blue because it will go behind the area of zonular weakness and you will not have good view. The red reflex will go. So what you need to do is inject viscoelastic and also in that area of the zonular weakness. And then over and above, you paint the Trypan blue so the red reflex will not be lost. As far as creating the rexes, it should be a highly retentive viscoelastic which should be placed so that to flatten the dome of the disc. Initiate the rexes from the area of intact zonules. You can start the rexes with the needle. After some distance, place the capsular hook and then go along. Leave 2 margin of the rexes so that there is enough capsular fornix to place the ring. And then when would you stabilize the capsular bag? A CTR, if you know it is not a progressive kind of zonular weakness, but it should be a CTR and along with the other anvils of support if there is going to be a progressive illness. We know that the CTR buttresses the capsular fornix. It also stretches the bag. So there are no wrinkles in the posterior capsule and there is no PCO. Sizing of the ring is related to the axial length. Longer the axial length, larger should be the ring. You would not place a CTR if there's an anterior capsular tear, PCR, incomplete rexes, or if it's a severely subluxated bag. How early would you place it? You can place it early enough, but remember, in a very hard cataract, in the process of placing a CTR, you might increase the subluxation. How late can you put it? You can put it late in a softer cataract, but sometimes it makes sense to use capsular hooks to stabilize the bag and do a knee surgery and then place the CTR. And now, the support systems could be iris hook, but that supports at the capsular margin only, and it is polypropylene capsular hooks or nylon hooks. And going further, I'm actually going to take you all to the surgeries because these are very relevant things, but paucity of time. Now, this is a case which things were going good. Suddenly, there's an iatrogenic dialysis. So, inject viscoelastic, deepen the anterior chamber. You could have placed the CTR, but it always makes sense to place the CTR late. Remove the cortex, keep checking whether the dialysis is not increasing, and then tuck in your CTR and then place the lens. Now, that's all there is to it. Now, in this particular case, the surgery phacodonosis was not seen on Sitlam, but while I started, I felt that the tactile stimulus was not there. It looked as if there was subluxation, no taking chances, place capsular hooks. And then I find I can easily rotate, I'm able to separate, I'm able to chop. But look carefully, that small area of zonular weakness superiorly. So I place a capsular hook, I stretch the capsular bag. Then again I feel no, I can't do phacoemulsification. I need to place a CTR, I need to stretch the bag, I need to support the capsular fornix. And then I do a supracapsular phacoemulsification, keeping in my phaco probe in the pupillar area. And then I put my lens inside. The cortex is still there. The lens is pushing back the PC because it could come trampolining in, and then I remove the iris hook, and then I remove the cortex. There are these steps which you need to take. Now, this is a case of a traumatic cataract with a large area of subluxation. It's a soft cataract, so just with IA, I have removed it all. And now I take a call to place a CTR, and believe me, this patient has been coming for 10 years and he's fine. But in today's knowledge, I would have definitely placed a CTS and not just left him with a CTR. Now, this is a case where there's a coloboma there. So I make a Hoffman's pocket, inject viscoelastic to prevent fluid misdirection there, plan my rhexis away from the area of zonular weakness, closer to the zonular area, there could be a rhexis extension. And then remove I do an IA and remove the cortex, and not the cortex, the nucleus. And now I am placed my CTR, but I'm placing my Ahmed segment too. Now, why do I place my Ahmed segment here was, a CTR would have been enough because this is not a progressive zonulopathy, it's just a coloboma with an absence of zonules there. But by placing the CTS, that asymmetric back contracture which could happen later has been avoided. Now, this is a case of a very significant subluxation. So I make a corneal pocket for a Hoffman's pocket, inject viscoelastic in that area of zonular absence to prevent fluid misdirection, create a small rhexis, but I'm going to use capsule hooks to stretch the bag. So make it more centralized. To what extent? Just with my IA, remove the soft cortex, but that's not enough now. So now what I'm going to do is, I'm going to loosen the capsular hooks. I'll just place my CTR into the capsular bag. So one support is done, and then I would remove it, and then I'm going to place a CTS into the capsular bag, a sutured CTS, and then anchor it to this Hoffman's pocket. If I have a severe subluxation, I'm not going to go into great detail. Here I would do an iris clip IOL after scooping out the lens matter and position the iris clip the way we all know, like place it and so that enough iris is tucked in. Now, this was a case where the patient came in after the primary well-done surgery, but probably the stabilization of the capsular bag should have been done to the scleral wall. The patient comes with a subluxated IOL bag complex. So you need to give it to your retina surgeon to do a vitrectomy, total vitrectomy, remove it, and then do an SFIOL. Post-operatively, there are different issues, but the most important message is capsular phimosis is a possibility in these eyes because of the partially weak area and all that. So even if you support it, it makes sense to polish the lens, not to make a small rhexis, and make some relaxing capsulotomies. So the essence of this talk is subluxated cataract is something we really need to understand well, why we do each of these steps. And if you do a good, careful surgery, we do well in all our situations. Thank you very much.
Thank you, madam, for that excellent talk. I hope this session was informative. I thank all my co-instructors for their excellent presentation and the delegates for their participation. Thank you all.